Hello, good evening, and welcome to session 3. And yes, today we'll be doing the real dissection, right? So we'll be talking about neck muscles. And just before we start, because today there'll be lots and lots of images, so this is needed, right? That image is displayed during this medical training session are for educational purpose only, and not all images are suitable for audience of all ages. Rest is all good. All right. Regarding the foramen oval, etc., see, don't worry because there'll be it passes that mandibular nerve and so many important structures. So the initial lectures where only the major foramens were shown, right, will as such be discussing those things in more detail, right? So let's focus on our today's topic, or you can always send a mail. Okay, so now in today's session, what we have done is we'll be talking about a muscle, right? The origin, insertion, and then pay good attention to its function. Because in head and neck, you need to see that things are in 3D, right? So there'll be rotation, there'll be lateral flexion, there'll be forward flexion, backward extension, etc. So let's start with what we already know. What we really know is, oh, happy Janmashtami to everyone. I'm good. Thank you. So we start with something which we already know. See, we have talked about that there were two joints. One was the yes joint and second one was the no joint. Right? These were the two joints which we have already talked about. So when we say yes joint, that means it is forward flexion, right? And that is, sorry, and that is handled by this particular joint. The joint between atlas and the occipital bone. So that is atlanto-occipital joint, right? Which we used to say as AO joint. Atlanto-occipital joint, that is for the flexion, correct? That is for the flexion. Plus, the flexion is the forward flexion, correct? That is a normal flexion, plus the lateral flexion. So that is this movement and the lateral flexion movement, right? So that is by this joint. Moving on to the next one. This is the joint which we are talking about. This is the no joint, right? No joint is between C1 and C2. That is atlanto-axial joint, right? Atlanto-axial joint. And this atlanto-axial joint, from this point onwards, we'll be calling it as AA joint. Fair enough? Okay. So when we say no joint, that means this is for the rotation, right? It is rotation of neck. Now, as we'll be discussing the muscles, it means these muscles, they'll be handling the rotation or forward flexion or lateral flexion or extension, right? Because yes means it is flexion, extension. So there'll be one set of muscles which will be going for flexion, and the opposite set of muscles, they'll be going for extension. Right, same thing would be happening in case of rotation. When one side of muscles are contracting, so then head will turn on one side. When opposite side will, other set will contract, the head will turn on the opposite side, right? So that's how things will go. Then we talked about those vertebra, right? So this is like C1, that is C2, it was atlas, this is axis, right? Though C7 was also into the atypical, right? But today we'll not be touching much to the C7, right? We are very much interested in this dense, right? The dense, also called as the odontoid process. Why so? We said that there would be intervertebral disc between C2 to C3, C3, C4, C5, C6 and onwards. But there is no intervertebral disc between C1, C2 or say atlanto-occipital joint, right? So occipital, C1, C2. Over here, there are no intervertebral discs. It means entire load is on those ligaments. And there are some fantastic ligaments. So that is what we'll be watching in more detail. So that layer by layer we'll keep on dissecting till we hit the bone. Right? That's how we'll go for it. And this is the typical cervical vertebra. In this, do remember that this one is the transverse process, right? And in that transverse process, 1 and 2, these are the two tubercles, right? Vertebral body, this is body, right? So the body is always anterior. So if the body is anterior, that means this particular is the anterior tubercle of transverse process. Why I am repeating? Because we'll be talking about this anterior tubercle, posterior tubercle of transverse process extensively during the discussion of our muscles. So this is like just I'm creating the base so that there is no confusion. Another important point is that regarding the transverse process of C1, right? Transverse process of C1, there is nothing like anterior or posterior tubercle. It is just a transverse process. Same thing is true even for C2. But so you have to keep that thing in mind. And this is the posterior tubercle, right? Posterior tubercle of transverse process. And this is the anterior tubercle of transverse process of C3, 4, 5, 6, 7. That's it. So this is the base which was needed, and rest of the things, yeah, this is all good. You know most of the, in fact, everything, right? This is the spinous process, and this spinous process is bifid, right? Bifid. This we talked about the transverse process, and it has got anterior and the posterior tubercles. Then this is like our articular facet, right? Articular facet, and that's the lamina and the body, and these are the pedicles. So that's it. These are the pedicles. Okay. And yeah, obviously this is that all-time favorite, the vertebral foramen, right? So foramen transverse area, vertebral foramen का. So foramen transverse area, right? Foramen transverse area, and it passes vertebral artery, vein, and that inferior cervical ganglion. Okay, and this is body. Now see, I just drifted. I'll be telling you at times that, okay, let's put a section, let's cut the whole thing. So it's like if we are cutting from here, right? If we cut from here, so what would happen if we watch from the posterior side, right? If we watch from the posterior, this is anterior. If we watch from the posterior side, that means this portion is removed, right? This portion would be removed. So we'll be able to see these structures over here. So it's like the spinal cord is over here, right? That's how we'll see. If we put a cut like this, and we watch from the side, so we'll be able to see the lateral structures, right? More as it arrives. Okay. So that was like intervertebral disc. Right? So all the vertebrae, they will be talking with each other. In between there'll be intervertebral disc. And that's how we see from the side. So this is the intervertebral disc, and this one, right? That's the joint. That is the intervertebral joint. So this is intervertebral joint on both the sides. Right? So that's how these joints are formed. Okay. Now there are so many things to discuss in this. See, this is C1 and that's C2. Right? This is C1 and C2. This is our all-time famous dens or the odontoid process. Now this is into the center, right? See, this is anterior, correct? That is posterior. This is anterior, posterior. Now, when we say that this dens is there, so this dens, it usually it is in the middle and it usually remains there only. Rest of the structures they move. So actually it is acting like a pivot, but it has to be stabilized, right? It has to be stabilized. So from here to here, this is, there would be one very important ligament, and that is called as the transverse ligament, right? So this would be the this would be the transverse ligament. Transverse ligament of this C1 is atlas, right? So this is transverse ligament of atlas. Then this dens over here and here. So there'll be two strong ligaments, right? They will be going up like this, like this. So they are called as the alar ligament. Alar ligament. These alar ligament, they are pretty strong, right? And they are alar ligament of dens, right? So as such, we'll meet all these structures within some time, but that's the whole idea, right? So let's see this. See, first we need to orient ourselves that what exactly are we watching. Let's draw, say this is one vertebra, right? And that's the spinous process. This is another vertebra and the spinous process. In between there is intervertebral disc. Okay, now visualize carefully. We are putting a cut. We are putting a cut over here at this angle. At this angle. So it means what we are doing is we are putting a cut on the neural arch, right? On the neural arch. So if we watch from the top, so it goes like this, right? That's the arch, because over here, right, that's the spinous process, transverse process, etc. But this is the arch which we are talking about, right? This is the arch. We are putting a cut over here. We are cutting the arch, right? So when we cut the arch and then we watch from the back, so it means when we'll watch it from this side, we are watching the structures which are anteriorly placed. It means we'll be able to watch the body, right? And we'll not be watching the spinous process, etc., because all those things have been removed. So here, I'll write it on the top that we are cutting arch, right? Arch is cut, plus on the top there is occipital bone, right? So occipital bone's posterior part, that also we are removing. So that's removed. Now see what we see. Immediately, first thing which you will watch is, this is dens. Dens is an anterior structure, right? It's an anterior structure. Basically, it is the body of C1. So that's the dens. If that's the dens, so this dens is very near to a big foramen. So that means this big one is our foramen magnum. foramen magnum. Correct? So that is foramen magnum. It means foramen magnum is in association with, over here, this is the joint because this one is C1, right? I'm sure you are properly oriented. This is C1. Just a minute. Let's take some good bright colors. So this is C1 and this has to be C2, right? Because dens is there. So this means the joint which we are talking about, this joint, this joint, this is between atlas and occipital bone. So this is our AO joint. And similarly, this joint, without any problem, you will say that that is the atlantoaxial joint, AA joint, right? So this is yes joint and this is no joint, right? This is yes joint. So far it is fine. Important thing is this. This is what? This portion. Well, foramen magnum, right? We learned in that in occipital bone, the portion of the occipital bone which is in front of the foramen magnum is called as the basilar part, right? So this is nothing but basiocciput, right? So we'll write it right over here. This is basiocciput or the basilar part of occipital bone. Occiput, right? Basiocciput. Do remember these structures because when we'll be talking about those ligaments, we'll straight away say that it will start from basiocciput and it will go over here, there, etc. Right? So that's it. This much is to be understood. Rest all is easy, right? Regarding the body and the lamina, etc. That is all fine. But this much is clear. Okay. This one. This is nothing but superior thoracic aperture, right? Because in our body, nothing is isolated. So today, when we'll be talking about some of the muscles, you'll find that those muscles, they are the same muscles which we were talking in upper limb, or there would be few muscles which will be coming into thorax. Yes, it happens. So over here, this is the first rib, right? This is the first rib, and that is the manubrium. And first rib is attached to T1. So it is this margin of on the back side and then all the way, and that is what it forms, superior thoracic aperture. So many structures would be passing through it and we'll be talking about it as it arrives, right? But this is just a basic bony layout which we need to understand. Now here comes our first nice image. This is how things really look like. Literally, beauty is skin deep. Okay. So we talk about those ligaments, right? We'll talk about those ligaments. In this, first, let's orient ourselves that what exactly are we trying to watch? Easy, this is mandible, so this is anterior, right? That's mandible. So this means this is spinous process, right? That's spinous process. Spinous process, and then they are splitting into lamina, right? So lamina is on both the sides. Collectively, the whole thing is called as the vertebral arch or the neural arch. So this one would be lamina. Fair enough, right? So that is lamina. Okay. Then laminas, they will be connected to those articular processes, right? The thing, and collectively, when you form all the articular processes together, it forms articular pillar, right? So that would be the articular process. right? And you know very well, superior, inferior, superior, inferior. So that's how everyone would be connected. And that's what we saw. That is intervertebral joint, right? That is the intervertebral joint. Now these joints, they are synovial joint. When we say synovial joint, that means there will be a capsule. Well, say actually odontoid process, yes, it is pretty big, right? It is pretty big. And today you will see that. Yeah, like and why it looks big in X-ray? Because in X-ray, the structures which are very near to X-ray plate, right, they are not magnified. There will be minimal magnification. It is exactly like, say here is one that wall, and you put a small ball over here and you project the light from here. So if this distance is more, right, so then there will be big image. So in head and neck, it never ever happens that the dense, right, that odontoid process, it is actually it's very near to the X-ray plate. No, there will be always be some distance. So that's why it would really look like a projected thing, a bigger thing. In real life, it is big, but not as big as it appears in X-ray, right? So you are right. Today also you will see that. Okay, coming back to this. So this is intervertebral joint, articular process, rest all good. Now we were talking about synovial joint, right? So in synovial joint, there would be two surfaces, two cartilaginous surface, and then there would be the capsule, and in between there would be fluid, right? We'll be able to see these things. Okay, so this is the synovial type of joint. Yes, good evening. Now see in this vertebral bodies, right? What we have now done is we have slightly rotated the structure, right? So this is how we were watching, right? And then we rotated it so that we can watch bit better the anterior aspect. So this is anterior, and what it is, these are vertebral bodies. Now it is good, right? These are vertebral bodies, because over there, now in the previous image we were not able to see the vertebral bodies properly because it was almost dead lateral, right? It was dead lateral. So now we are watching vertebral bodies. That means over here, this is the intervertebral disc also, we see that, right? So that is quite fair. From vertebral bodies, what goes out? Transverse process, right? So that's the transverse process. See, that's the transverse. What did I write? Transverse process. Transverse process, right? So that's how it looks like. Now see, things look bit weird when we actually look at the real images. So as we'll start removing the tissues layer by layer, you'll start finding it that yes, it is making much better sense, right? So here it is now. This is dead posterior, right? Dead posterior. And in fact, do remember this image. This is posterior view. That's the occipital bone, right? Occipital bone. In occipital bone, do remember those nuchal lines? There was supreme nuchal line, then superior nuchal line, and the inferior nuchal lines, right? Supreme, that was at the topmost, superior and inferior. Today, they will also be coming into picture extensively, right? They were called as the nuchal lines. Nuchal lines, right? Okay. Now, this is posterior. So now we'll be putting a cut. Now this cut will be going through the articular pillars, right? You remember what is articular pillar? That means superior, inferior, superior, inferior, superior, inferior, right? So when collectively all of them, they are over here, so they are forming the articular pillar, right? All the articular surfaces, right? vertically, when we saw them, we call that articular pillar. So now this is a cut through articular pillar. Articular, sorry, articular pillars. Still, if there is any doubt, no worries. As soon as you'll see the next image, it will be clarified. See, in other words, what we are doing is, we are not really putting a cut in the sagittal section, right? It is parasagittal. So it means we are passing through that plane where those joints are formed, and see the joints. Here it is. This is what I'm talking about, this portion, right? See how nicely we can see a joint. This means this is the area which we are talking about, right? Watch it. This and this, right? These are, this one would be the inferior articular and another vertebra superior articular surface, right? So these are all articular cartilage, correct? They are articular cartilage and they are smooth, right? They are smooth. This is a synovial joint, right? This is a synovial joint. Now the speciality of synovial joint is that there has to be a fluid, because it works like that gear system, right? Like in car, in bikes, there is a gearbox, and in that gearbox is completely packed. The gears keep on moving inside, and then there is gear oil. So same way, this synovial joint, it is acting like a gear oil, right? It is for lubrication, no doubt. Not only lubrication, it is for nutrition also, right? But right now we'll just talk about lubrication. So there would be the synovial fluid, right, over here. But then the whole thing has to be packed. So that thing is packed with that is what is called as the synovial, that is what is called as the joint capsule, right? So that is the fibrous joint capsule. This is the reason we put the cut through articular pillars, so that we should be able to see these joints properly, right? Because the cut was going through it. Nuchal is back. What your body is looking like, lizard? True. So once again, we are back to that, right? Now this time, let's put a complete midline cut, right? We are going for the midline cut, and see what happens. When we are going for midline cut, say this is what our brain tells, yeah, this makes sense, right? So previously we were watching those intervertebral joints, right? Because it was through articular pillars. Over here, this is easy, right? This is body, this is intervertebral discs. Now these discs, they are fibrocartilaginous, right? They are fibrocartilaginous. And they are very firmly attached with the vertebra. And we talked about it, right? There was annular processes, and that's how they are firmly attached. So they are firmly attached. This is the reason that the movements are restricted, right? The movements are limited and restricted. So with spine, there are very few movements, but because its function is stability. So these are the spinous process, and in between what you are watching, that is the canal, right? In which there would be the spinal cord. Okay. Now over here, we already talked about it, right? But this is the actual atlanto-occipital and atlanto-axial joints, right? These are the atlanto-occipital and atlanto-axial joints. And we just say one thing, how to differentiate between disc and joint? Uh, Disc can, because joints they are laterally, disc is between two bodies, right? So there should not be any trouble. Say what I'm trying to say is this, right? The disc would be always like this, right? In between the bodies. And those joints, see, the joints are always lateral, right? Because this is a complete midline section, so we are not watching any of the joint. If we really want to see the joint, we have to put the cut over here. That's what we did, and we saw it over here. Correct? So these are the joints. And this is how the discs would look like. Say the totally different, right? And the size. So this is about, say, atlanto-occipital and atlanto-axial. And just we need to say one thing, that there is no intervertebral discs. Right? There are no discs in this. But all the movements, all the major movements, they will be over here. Right? So this is one important point, that all major movements of neck, right, of neck, they will be here. So that's the reason that we have to talk in detail about two things. One, which muscle will be handling this movement. But if the only muscles are acting, then they won't be able to give any stability. So first thing we need to know about that, where are the ligaments? Who will be giving the stability and who will be restricting the movement, so that that movement is not going overboard and it is going for extreme flexion or drop of head on front side or back side, etc. Right? So let's see the ligaments. The first important ligament, something which is, this is back side, which is called as the nape of the neck. Nape of the neck, or the back side of the neck, or the nuchal area. Right? Or the nuchal area. This is what is called as the nuchal ligament. This one. This is a very strong fibrous tissue. Strong fibrous tissue. In fact, this nuchal ligament is so important that it will be giving, at this point of time, just remember that it will be giving surface to some important muscles, right? Splenius capitis, trapezius. But at this point of time, just keep it in mind that there would be splenius capitis or trapezius, right? These muscles, they will be getting the surfaces for attachment on nuchal ligament. That means nuchal ligament is pretty big. What could be its function? As we always say, we don't have to cram anything, right? We don't have to cram. So think of it that if this ligament is on the backside, such a strong ligament, what would it do, right? Say this is head. Head won't drop like this. If the head would try to drop like this, that ligament is putting some restriction. It is limiting the movement. So that's its function, right? It limits forward flexion. Forward flexion, right? Of neck, obviously. Everything will be talking about neck and cervical spine. So every time we won't really say that it would be restricting forward flexion or backward extension or hyperextension at cervical and of the neck. It is obvious, right? Because today we are talking about it only. Whenever things would be deviating, because shoulder would come into picture. So at that point, we'll specify. Otherwise, we are talking about all the movements related to neck and cervical spine. And second is provides surface area for muscle. Surface area for muscle. That is for attachment. And two important muscles, which we talked about it. At this point, it is completely fine if you don't even remember the name. From the past experience, I remember that when I say don't remember, you always remember. So deliberately, I said this thing. Okay. See, this is another dissection. In this, if it is the nuchal ligament, right? Nuchal ligament, so important. So we need to know that where exactly it is attached. Now it is all the way from the occipital bone. So this is occipital bone. In occipital bone, we said that there is, if we have to select a structure which is into midline, and it has to be most prominent, most powerful structure, that then cannot be any other structure but external occipital protuberance. Correct? And that's the most powerful structure. So, okay, it is attached into the midline. From there, all the way it goes down till covering the, it has to cover the entire neck. That means it has to cover the entire cervical area. So it lands, it goes till T1. And in T1, again, the central structure. So it has to be the spinous process. So very easy. So from external occipital protuberance, it goes all the way down. Right? So these are the attachment. Easy to remember. In fact, all the structures, they are like that. As such, if we look at it in the form of table, then it looks so confusing that sometimes it is telling anterior, sometimes it is telling posterior. Then it is interesting compared to, well, every region is interesting because every region has got its own speciality. Okay, and actually, when you start learning the brain, right, it's actually very funny. We'll come to that. Okay, here it is. Now see, as I said, that's the point from where now you have to start visualizing that what exactly are we doing. This is anterior view. Okay, we have not cut anything. This is completely intact. What we are now watching is, see, this is one vertebra, this is body of second, right? And let's say this is spine. We are watching, this means if we are watching it on the spinous process, it means we are watching from one side, right? So that means this is anterior, correct? If this is anterior, so then there is one ligament which is over here, all the way from the top till bottom it will go, and as it is anterior, so we'll call it anterior. From the direction it is longitudinal, so it is called as longitudinal ligament, is ligament. Okay, so this is anterior longitudinal ligament, right? Easy to understand. Okay, now that means anterior longitudinal ligament, right? This is anterior longitudinal ligament. This is going all the way anteriorly, right? But important point to remember is that there it is anterior, so there has to be posterior. Otherwise, we would have called it longitudinal ligament, correct? Now, this ligament speciality is it starts as a weak ligament, and then as it goes down, it becomes stronger and stronger, right? So this is powerful and stronger as it goes down. As the vertebral bodies, they become bigger and bigger, this ligament, it starts getting more and more area to get attached. So it becomes powerful and powerful. Those are our cute cervicals. So as such, so they are with those small, very delicate bodies, right? So as such, anterior longitudinal ligament won't be getting bigger surface. So it will be a bit weaker. And as it goes down, it will become stronger and stronger. Okay. So as this anterior longitudinal ligament, it runs for the entire length, right? So we'll write it anterior longitudinal ligament, right? Putting in quotes so that there is no confusion. Runs whole length, right? Runs whole length all the way, right? And if we really want to watch it, simple. Remove all the external structures, straight away watch the spine, and in front you will be watching the anterior longitudinal ligament because it is on the anterior surface of vertebral body, right? Anterior surface of vertebral body. Now it has to start from, it will start from C1, right? That's the thing. It has to start from C1 and then it will go all the way down. But C1 has got no body, right? C1 is our atlas, right? From C2 onwards, so there is everything is okay, right? There are bodies, so it will be attached on the body. So here it makes sense, right? They will be connected like this. But what about C1? C1, so there is no body. In C1, so it was just the anterior arch. You remember anterior arch? There was anterior. Okay, let me show you. I remember there was one nice image. Here it is. See, that's our C1. That's our C1, right? And that's the arch, right? So this is what is called as the tubercle on anterior arch, right? On the arch or the anterior arch of atlas. So yes, that's the point from where this anterior longitudinal ligament would start, right? There it is. Yeah. So we'll write it over here that tubercle on that anterior arch, right, of C1, and then it goes down. So this is the important point to remember, right? So do remember this. For rest of them, it is just the body. So that's all fine. Okay. Now, if that is anterior longitudinal ligament, posterior longitudinal ligament is super interesting because that's the ligament which we need to see in detail. And once you know this, so many doubts would be completely clarified. You will understand that, okay, unnecessarily so many complex names are given, but as such, they are so easy, right? Because if you tell someone tectorial membrane, right, looks so heavy, so impressive. And when you'll see it, you'll find, acha bas itna hi. It is like that. Okay, first let's orient ourselves that where exactly we would find posterior ligament. So if this is the body, this is where the anterior longitudinal ligament was there, right? And then this is the vertebral foramen, and that's the transverse process, and that's the spinous process, right? So here is the location of posterior longitudinal ligament. This is posterior longitudinal ligament, right? So if we really want to see posterior longitudinal ligament, we have to take a section. We are taking a section, right? This is which section? This is a sagittal section. So we are splicing it for posterior longitudinal ligament, right? So this is posterior and this one is anterior. this is anterior. So where are the bodies? Well, these are the bodies, right? That's the body. So our area of focus would be this, right? That's the point. That's what we are trying to watch, correct? Okay. Before that, let's orient again properly. See the same structures. What was this? This opening, this one. Well, it has to be foramen magnum because we are going right into the sagittal section. So this is foramen magnum, right? So this is our foramen magnum. And any structure, foramen magnum, any structure which is in front of the foramen magnum, now you know it so well and you will call it, this is basi-occiput. Basi-occiput, right? So that is basi-occiput. And what are all these? All these, they are all those sliced vertebral arches, right? Those vertebral arches, they were going and we cut it. So that's what we are watching. So that's okay. Right now we don't write it. We focus on that which area we really want to see. So we want to see this area, right? So that is the area of posterior longitudinal ligament. Now regarding this posterior longitudinal ligament, speciality is it is broader and thicker. Above, right? It is above because as it goes down, actually, right, slowly and gradually, it is over here, there is a big space available. So broader and thicker above, and it becomes smaller and thinner as it goes down. So now see, we are orienting ourselves again in a different way. See, this is now like a coronal section, right? So now I'll get a chance to draw that crown, right? So, right, that's a coronal section like this. So it means this is foramen magnum, right? That is foramen magnum. I'm erasing it. Just want to show something interesting. It is, we have cut it like that, right? And then we are watching from the back side. So it means we are watching anteriorly. So view is something like this. That's the vertebra, right? And say it has been cut like this. So that spinous process is removed, right? So this is removed and we are watching from here. It means we are watching the posterior surface of the body, of the vertebra. And that's it. This one is posterior longitudinal ligament, right? So far it is fine, but its highest part, see the part which is going all the way to the basi-occiput, because once again, this is the foramen magnum. So that means this is basi-occiput, and the part, this posterior longitudinal ligament is going all the way up to the basi-occiput. Now think it like this. Basi-occiput was here, then there was foramen. So it means these fibers, they will start all the way and they will go down. Consider that this is the vertebral bodies. So from basi-occiput, fibers are going and all the way they are going down. So these fibers, which are the topmost fibers, just a nice name is given. Don't know to impress whom, but it is called as the tectorial membrane. Right? So if someone asks, no need to worry at all. Tectorial membrane is nothing but those fibers, posterior longitudinal fibers, right? Posterior longitudinal ligament fibers, the highest part, which is starting from basi-occiput, that is called as tectorial membrane. That's it, right? So this PLL that is posterior longitudinal ligament. Set. One more angle. And yes, you are right, in head and neck, through and through, means till the end, we'll keep on watching one structure from various angles, right? Because the conceptually, it should be extremely good. And now see the dense, right? See, this is dense, right? How powerful, right? So now it's fine, right? What section are we talking about, right? This is right from the middle, so it is as good as it is a sagittal section, right? So it is a sag section. So if it is a sagittal section, that means this is anterior, that's posterior, right? Bodies are anterior, so this is dense. Dense is of C2. So this dense, it will go all the way, right? And surrounding it is the ring of that arch of C1. So that means this one is C1 and it is its arch, and it is its anterior arch because it is on anterior side. And this part is the posterior one, correct? And of C1, it is arch. So that is good, right? That's the complete ring. But because we have put a cut, so it is dense is helping that, okay, anything in front over here, it is C1, anything posterior, that is C2, anterior and posterior arch, done. It means this particular joint, right, that particular joint, that would be what? That would be AA joint, atlantoaxial joint. Fair enough. Now, we are not interested in that. We are interested in this part. That this is okay, this is intervertebral disc, right? Not a big rocket science, but it is this part. Say when we say that this bone is occipital bone, right? That occipital bone, there is a big foramen. So that foramen is this, right? And that foramen is what? That foramen is foramen magnum, right? It is foramen magnum, because via foramen magnum only the brain spinal cord, they will start entering into the spinal canal, right? And that's how they will go. So it means anything which is in front of foramen magnum, it is what? It is called as basi-occiput. So is there any bone? Yes, here it is. Here it is. This bone. This is a bone, right? See, dense is a bone. This is a bone. So this bone is what? It has to be basi-occiput, basilar part of occipital bone, right? Basi-occiput. So it means those tectorial membrane, they were starting from basi-occiput. Fantastic. That's what we are watching. See, these are the fibers. These are the fibers, right? I'll show, first I'll draw, then I'll zoom it, right? So you'll be able to see. These are the fibers which are starting from basi-occiput. Now till what point they are going? Well, they will go till the body of axis, because there is no body of C1. So it has to go to C2. So where is the body of C2? That is the body of C2. So these fibers, they are going up to this point, up to this point. So that's it. This is what we are watching is tectorial membrane. That is tectorial membrane. Okay, I have to erase it, no? Then I'll write it. And I'm zooming it. Watch those fibers. These are the fibers. And they are, see, landing over here. But here they are finishing it. This entire portion, right? This one, that one. That is tectorial membrane. Right? That is tectorial membrane. Basi-occiput, to C2 body, right? Body of C2. What is looking like hen's face? Acha, this one. But that is amazing. So this is the beak, right? And this is the eye. So another hen is coming. So above what we saw was tectorial membrane, and then all the way from C2 onwards, and we'll just call it posterior longitudinal ligament, right? So C2 onwards, it is that, right? All the way down. So that's fine. Okay. Just for the reference, let me take you back so that it is completely clear what we are talking about. See, in this image, right, this is tectorial membrane, right, and then this goes all the way to posterior longitudinal ligament. What if right from the base occiput we scrape off that entire posterior longitudinal ligament? We remove that posterior longitudinal ligament. So when we say PLL, posterior longitudinal ligament, we also remove tectorial membrane. So then what do we see? That's what our next structure is coming up, right? So this is as a reference that what we are about to remove, right? Same view, and and this is foramen magnum, right? This is foramen magnum. So that's foramen magnum, and we have removed the tectorial. In fact, we have removed the posterior longitudinal ligament. Even if you write tectorial membrane, it's one and the same thing because we are just focusing on the top area, right? So tectorial membrane, that's removed. So just underneath what you are watching, and you'll be very happy to know that what it is. This one is long awaited, that transverse ligament. You remember transverse ligament of atlas, right? That transverse ligament of atlas is now over here, right? So there was dens, right? And then this was C1 and that ligament which was going like this, which was preventing the backward tilt of the dens, right? Otherwise, dens could tilt backwards. So this is that. This is that. Now, right? Hope now it is clear, right? What we are watching from the posterior side, right? We have sliced so that we can watch. Say this is the vertebral body, right? We have put the cut. We are watching from here, right? We are watching from here. So that's the body, right? This is just for the orientation. So we are watching the posterior surface of the body. But over here, in this case, the dens was there. On the dens, there was anterior this transverse ligament. This is the transverse ligament. Right? So that's the transverse ligament. Correct? I'll just lightly color it. Bus, this much. Right? This is the transverse ligament. They are all foramens, right? Don't worry about it. So this is anterior. This is transverse ligament. Fine. Transverse ligament of atlas, right? Now we are adding something extra to that. See, this is transverse. So then there is something over here, right? Some fibers which are going up, few fibers which are going down. So very rightly, we'll be calling these fibers as superior band and the inferior band, right? Superior band and inferior band. Superior band, they should go where? Well, so easy to say, because this is our foramen magnum, so that means this is base occiput. It means those superior band, they will be going towards base occiput. And what about those inferior band? Inferior band will be going down, right? It will be going down. Atlas has got no body. And over here, so the nearest body which will come is the body of axis, right? Body of axis, or C2. So it will go over there. So thus we have got transverse, superior band, inferior band, and this thing, which is like this, collectively it is called as the cruciform ligament. Cruciform ligament. Like a cross, right? This is like a cross, so that is called as cruciform ligament. Superior band, base of occiput, inferior band, body of axis, and the transverse ligament, right? Okay, now we are removing cruciform ligament. Right, so we remove this cruciform ligament, removed. And what we are watching now is, this is the neat dens, right? This is the dens. We have reached to the bone. And then from the dens, do you remember we said two strong ligaments, they will be going up? Well, they are there. This one and this one. They are strong alar ligament. They are strong alar ligament. Is this cruciform ligament on cruciform eminence of occipital bone? Well. See, can it be? Can it be? It cannot. Because what was cruciform eminence in occipital bone? It was inside the skull, right? Cruciform eminence was inside the skull. Inside the occipital bone, right, there were all those venous sinuses, and they were forming the cruciform eminence. You remember that? Over here, we have come out of the foramen magnum, right? This is the foramen magnum. We have come out of the foramen magnum, and then we are forming this cruciform. So, and where exactly it is? It is at the level of C1, right? So those cruciform eminence, what we are talking about, for that what we did, that we took the skull, we removed the frontal part, and then we were watching. Right, then we were watching that, okay, there is that cruciform eminence, right, into the inner aspect of the occipital bone, right, to the squamous part of the occipital bone. Over here we are out of the skull, right? We are just at the junction, right? We are at the junction, but it is not inside, we are outside. So they both are different, right? Ghost Medusa. I think Prajul, you got the point. In case if not, right? In case if not, just send a mail, right? I'll explain again. Okay, so this is how it looks like. The important is that now this is the bone, and on top of the, like, on both of its head, these are the horns, and they are like alar ligament, strong alar ligament, strong support. Okay. Again, orient that where exactly are we? Just the bones. So that's the dens, right? He's sitting like a king. And this one is AA joint, atlantoaxial joint, right? This one is atlanto-occipital joint. Good, right? And these are the attachments. So this is over here, right? That's the alar ligament. That's the alar ligament. That's how they are attached. So this portion is what? As we said that this is the atlanto-occipital joint, this one. So that means this area, this one, or over here we draw it, this one. So that is occipital condyle, right? So that is occipital condyle. Oh, sorry, that's okay. Occipital condyle. So this point where it is inside occipital condyle, right? And over here, this part, well, it is the lateral aspect of dens, right? It is the lateral aspect of dens or the odontoid process. They both are odontoid process. So that's how the alar ligaments they are attached. One more view. Now it really looks like hen. Okay. Now I think hen has got some food also in its mouth. No? So this is a side view, right? This is a side view. Things which are very clear to us. First thing first, what we need to see is that those fibers, they were coming from there, right? They were coming from there. So they were like tectorial membrane, right? If we remove tectorial membrane, we were watching, that's the transverse ligament of atlas, right? That's the structure. One more thing which we would like to see in this, that's the body. This is anterior, that's posterior. These are the arch, right? That's the spinous process. There's this everything. So over here, this is the area. That is ligamentum flavum. Right? This is ligamentum flavum. So this ligamentum flavum is actually yellow colored. So that's why deliberately I drew it in yellow color. It is yellow color. And it is yellow color because of elastine. Because of elastine, right? This is a spring type of collagen, right? I'll just write down. Spring type collagen. So if it is asked that where exactly is this the ligamentum flavum, it is the arches which are connected with each other, right? Till this point, we were telling anterior longitudinal ligament means anterior surface of the body. Posterior longitudinal ligament, posterior surface of the body. And then what about the sides? That's where ligamentum flavum would come into picture, right? So arches connected to each. So when we are watching from the side, right? When we are watching from the side and this much portion, if it is removed, so this is what we are watching. That is ligamentum flavum. That's the ligamentum flavum, right? Now, if that is ligamentum flavum, so here it is ligamentum flavum. But then there are this and this. This is the AO joint and this one is AA joint, right? That is. So here there is loose flexible fibrous tissue, and that is what is called as the AO ligament and AA ligament. Atlanto-occipital ligament, atlanto-axial ligament, this is where what it is, where it is inside, right? It is inside. It is the loose flexible connective tissue. Now, what's the logic? Because this is the area where there will be maximum movement, right? There will be maximum movement. So because of that movement, there is more flexible fibrous tissue. And that's why this AO joint and AA joint, they are getting the special privilege that they'll be having loose connective tissue. Meantime, this classically seen, it is same old transverse ligament of atlas. Now let's do one thing. Let's create one hypothetical image, right? So that it will make things much better. We'll use different color. Say that was the dense, right? That was the dense. And in dense, at the deepest level, these were what? These were LR ligament, correct? That was the LR ligament. Then on that LR ligament, there was that cruciform ligament. So let's change the color, right? Cruciform ligament. So cruciform ligament was formed by that transverse ligament of atlas. And then there was superior band which was going towards the base occiput, correct? And then there was inferior band which was going towards the body of C2. So this is base occiput, and this was going towards the body of C2. This was the transverse, so it is laying on top on that. And then this entire thing was covered with that posterior longitudinal ligament, right? So this entire thing was covered. It was covered like this, right? And this top one was given a special name, and that is tectorial membrane, right? And rest of that was all the ligament, all the way down, right? So this is how those things are arranged into the layers. Okay. So it means now we know about these many structures, right? You know very well about anterior longitudinal ligament. You know about posterior longitudinal ligament. You know about the tectorial membrane, right? You know about the cruciform, right? Cruciform ligament, right? In that there was the transverse ligament, there was superior band, there was inferior band, right? And you know about the ligamentum flavum. Also, you know about those synovial joints and everything, right? So if this much is clear, this means these many structures, they'll be giving stability to the head, with respect to rest of the vertebral column. Now we start with the movement, that how exactly the movement should start, right? How exactly things would move. And for that, we need to talk about those muscles, right? Trust me, it is so easy, right? It is really easy. And you know most of them because names are very familiar. So let's start with the muscles. Obviously, neck muscles. Size of the muscle will be very small as compared to, so don't compare any of the muscle with sartorius or quads, right? They are very delicate muscles, very small muscles. So deeper first. So deeper muscles first. When we are talking about deeper muscle first, it means we'll be starting with the bone, right? And the bone, it has to be the occipital, right? The occipital bone. Let's talk about some straight muscles first. And one very interesting thing, any of the muscle, if it has got the name capitis, that means it will definitely be going to the skull. Any of the muscle whose name is cervicis, it means that muscle will be playing into the cervical region only, right? It will be somewhere into those vertebrae only. This cervicis, it can also be lovingly called as coli, right? So they both are same. Rectus is rectus, right? That means straight. And if there are more, so then we'll call them major or minor as per the size. That's it. Technically, you have learnt all the muscles. Right? So let's start with one. One and two. Two muscles. This is one muscle. This is another muscle. Right? This one and this one. So first watch it here. Right? This is much better. Then we'll go back to that image again. So over here, these two muscles, they are straight muscles. So they will call them rectus, right? Because straight, and they are going towards skull. This is occipital region. Right? This is occipital bone region, bone, right? So this is rectus capitis. One is bigger, one is smaller. Looks wise, straight away it is telling who is smaller. So we'll call this as minor and this as major. So four muscles done on both the sides, right? Two on both the sides. So rectus capitis minor, rectus capitis major, right side, left side. Fine. Regarding the minor, where do you see it? Right? This is the minor one. This one is minor. And it is over here. Immediately after the occipital bone, so this means it is with respect to C1, right? And it is attached on the C1 posterior arch. Posterior arch. Two, we said that there are nuchal lines. This is supreme nuchal line. This is superior nuchal line. And then in that case, this one would be inferior nuchal line, correct? This is supreme, topmost. This is superior. And this one would be the inferior nuchal line. Yes, you have said everything about it, right? In fact, with so much of clarity that this minor would be landing on the posterior arch of C1. Two, it is attached on the inferior nuchal line. Nuchal line. Correct? And that small muscle, right? That small muscle which is attached on the posterior part of the head. And then there is C1, small muscle, when it will contract, right? doesn't matter, right? It would be a small contribution of this small muscle, right? So what it will do, when head is like this, it will contract and it will do like this, extension, right? Extends head. So this is, it extends head. But looking at its size, we won't say that it is a powerful extensor. No, it cannot be, right? It is a chota extensor, but it is fine. So what is the purpose? These are for delicate movements, right? Those who are into dance, they know the importance of these small muscles, because these small muscles, they are under supreme control. So that's how they give so much of specific movement. And one of the very fine sciences, that is that is what is called as the micro expressionism. That is, if literally you need to shoot that person, right? Not that shoot, but you have to say with a camera at a very high frame rate. As soon as in the interrogation, if the question is asked, you are shooting that person with a very high frame rate, and then you see that what really happened, what happened to that shoulder, what really happened to that neck, all these things, they will come into picture, right? That is a very precise, very advanced science of, say, uh, body language, right? And it has got some forensic values also. Coming back to this, because that is such an interesting topic, right? We can talk about it for hours together. Okay, regarding this major one, right? Major is where it is attaching. Again, it is inferior nuchal line, है ना? So it is going on that inferior nuchal line. And we don't have to even cram that thing. So we can really say inferior nuchal line medial aspect. And this one would be obviously the lateral one. Easy. And this inferior nuchal is going down, right? It is going down. Where is it going? It is going on C2, right? Next stop is C2. And in C2 centrally, it is the spinous process. It is the spinous process. So from spinous process to inferior nuchal line lateral aspect, and C1 posterior arch to inferior nuchal line medial aspect is the minor one. So done. Rectus capitis, minor and major, they are done. What this will do, this major one, well, its size is bigger, right? So obviously extends the neck more confidently, right? Extends the neck, but because it is laterally attached. So what happens when one muscle contracts, only one side contracts, right? It will lead to movement on the other side. That is what is called as the rotation, right? So when this side contracts, rotation on the on right side. When left contracts, rotation on the left side. So it means it extends the neck, and we'll also say it rotates the neck, right? So these are the two movements, because size is bigger and it is connected on the lateral aspect. So it is like a mechanical advantage. Those who are connected into center, they won't be able to, at the most, they will be able to do just this much minor movement, right? But not the bigger movement. So this is about rectus capitis major and rectus capitis minor. Now see those muscles. Now you will like it. Right, as far as possible, I won't be writing much on these dissected images, because if we keep on writing on it, you will lose the real picture, right? So no confusion, just I write this much and this much, right? So this is rectus capitis minor, and this is rectus capitis major. Fine, straight muscles. So if we have understood this, let's rotate the head slightly. So now we are rotating it like this, right? So it means this is our rectus capitis major, right? Just for the reference. So then we come across two muscles over here. One which is like this, and second it is like this, right? Two muscles. 1, or let's name it as 1, 2 were major and minor rectus capitis. So let's say this is 3 and this is 4, right? To appreciate it better, let's see it this way. This is much better. You know, we are talking about this is 3 and this one 4. They are oblique. So let's call them oblique. Relatively, previous two were straight. So these are oblique. Again, skull is involved. So capitis. Capitis. One is above, one is below. So we'll call this as superior. And we'll call this as inferior. Well, for a change, this inferior is bigger. So we'll put a tick on it. So it means this is oblique capitis inferior and oblique capitis superior. Right? So these are the two things. What could they do? Well, for that we need to see that where exactly are they attached. Then and then we'll understand it. So let's say this superior one, right? Superior one, where it is attached. So looks wise, it is telling that one thing to you will know instantly that this is on superior inferior nuchal line, right? Because all those three muscles, this one, these two, rectus capitis minor, rectus capitis major, and the lateral most part of the inferior nuchal line is this superior oblique capitis, correct? But it is going on where? It is going obliquely to transverse process of C1, right? So from transverse process of C1 to that occipital bone, right? To be very specific, inferior nuchal line lateralmost. Lateralmost. So now thinking, what can it really do? This C1 is fixed. And then, right, why C1 has to be fixed? We'll come to that. Now, this superior one, right, it is, say this is C1, right? C1 is fixed because entire spine is fixed. Only the head is to be moved. So keeping this thing as a base, when it contracts, so it will tilt the head on one side, right? Interesting, right? So this is the head and it is connected. This is the head and it is connected over here, right? So when it contracts, it would tilt, right? When opposite side contracts, it would tilt that way. And when both of them contract, it will tilt this way. And this is what is called as the extension. So here, its function would be lateral flexion and extension, right? And it extends the neck. So this is done, right? Now, as you very rightly said, you pointed out that this inferior, it is not on going on skull, right? Still, it is called inferior oblique capitis because these muscles, they are working in set, right? So that's why, yes, it should have been named as cervices, but because its function, it is with respect to that movement, and that's why it is, because it is working like a set, that's why it has been named like inferior oblique capitis, right? There are only few exceptions where it would be like this. Otherwise, in most of the cases, we'll just see that all those long muscles, capitis or cervices, simply touching the head or not. Okay, so regarding this inferior capitis. Inferior capitis, as we saw, see that it is starting from where? Transverse process C1, right? On one side, it is transverse process C1 laterally, and medially, it is coming into center, right? So from center, it is going towards the side. So when that would contract, what would happen, right? It has got a rotational axis above. It has got a rotational axis above. So when that would contract, it is for the no, right? It is for the rotation of the head. So see, transverse process, it's a long muscle, right? It's a long muscle. So when the muscle is long, there would be the mechanical advantage. So this is a long muscle. When it contracts, it means it will tilt the entire head like this. So that is for the rotation. So this is, just remember, this inferior oblique capitis, this muscle, from transverse process of C1, that means it is on one side, to spinous process of C2, which is in the center. So that would result into the rotation, right? A rotation of neck. So here it is for the no movement, right? So four muscles down. Now, this is anterior view, right? Let's skip this and we come back to this after one image, because this would be much better, right? This thing makes much better sense. So no need to say that this is anterior view. Mandible, such a big mandible is there. So this is anterior view, right? The muscles which are connected over here, they are called as long muscles. They are the long muscles, right? So we'll call them longus. Those muscles which will be landing on the occiput, right? Skull. So they will be called as longus capitis. Those muscles which will be playing into the area of cervical region, so they are called as the longus cervicis, lovingly called as coli, right? These muscles, as such, they are small muscles. Collectively, joint effort is like, it looks like they are long muscle. Otherwise, they are chota muscles. Right? This is the reason that they are not very strong movers. They are weak flexors. Even without discussing more, straight away we said that they are weak flexors because they are anteriorly situated. So when they will contract, right? Obviously the flexion, right? So they are the weak flexors of head and cervical spine. Yeah, right. So how are they arranged? For the capitis, it is interesting. Fibers all the way from base occiput, right? So from base occiput they start. Base occiput to, they are going to this transverse process of C3, C4, C5, right? C3, C4, C5. So that's why it is capitis. What about the cervices or the coli? All longus, right? Longus, both of them, longus. They start their journey from C1 to C4, right? From the body. From the body. And then they go towards C5 to T4. T4, the body. So that means these muscles, right? As such, if you really see that they will be working from C1 to C4, right? C1 to C4, and they are on the body. So that's why, again, small muscles, so they all are collectively weak flexors, right? Now we see this. So look, say they would actually look like as if they have fused, right? But we can say this one, right? Top one, they are longus capitis, right? And these ones over here, which are more in to the center, they are like longus cervicis or coli, right? And this is anterior view. Okay. These are the muscles which you should know very well. These muscles, very famous, right? And they are scalene. This scalene gang, right, it has got three muscles: anterior, medius, and the posterior. And these are highly influential muscles, right? They deal, even big structures, they are passing through them, right? Very important. And one of the important structures, I think you remember that, right? We'll come to it. So here it is: anterior, medius, and this one is posterior. So they are called as the scalenus anterior, scalenus medius, and scalenus posterior. And yes, this is like anterior view, right? We are watching anterior. So that's the rib. This one would be the clavicle, right? This one is clavicle. This is much better, right? It is giving much better idea. So here it is, scalenus anterior. Now see, a funny thing happened. After at around 7:20, it just struck me that are these scalenus anterior, because this is scalenus anterior and this one is scalenus medius, right? And this one is scalenus posterior. Now if you look at these muscles, right, they really look like gundas, right? Such big strong muscles. And these muscles, right, no way they are looking like such big monsters. The reason is that this angle, right, it is just from the lateral side. So that then I added one image. Now they look so beautiful, right? So this is scalenus anterior, right? A big one, scalenus. This one scalenus anterior, right? See how gorgeous this scalenus medius is there, and this even scalenus posterior, that is also good. So it is not like that these muscles over here which we are watching, they are that weak, right? It was just absolutely the lateral angle, so that's why they look like those Sharif thin muscles. Otherwise they are like these, right? These are their real images. They are asli gundas. So scalenus anterior. Now see, I'll just make some space, right? Because we have got lots of images for this scalenus anterior. Means all scalene muscles. Focusing on scalenus anterior. Now see, this is anterior muscle. This is where I told you about that in transverse process, right? In transverse process, there is anterior tubercle, there is posterior tubercle. I'll write some things three times. Few things I'll write three times so that it should stuck in your brain that yes, it is exactly like that. First thing first, right? Step by step we'll add. Scalenus anterior, anterior, so anterior tubercle. This is easy, right? Anterior tubercle. When we say anterior tubercle, so it has to be of transverse process, right? It has to be transverse process because this muscle is not in the midline. It is on one side. So that's why it has to go to the transverse process. Now this is important. C3 to C6, right? And then it goes all the way to the first rib. On first rib, there is a special seat given to this, and that is what is called as the scalene tubercle, right? So it is a small area which has been donated to it, and it is called as the scalenus or scalene tubercle. Think of what it can do, this muscle. To be very honest, these muscles, they are one of the important muscles which are for deep inspiration. Because it is connected to first rib. So if the head is kept straight and when you breathe in, so it means it will lift the entire first rib. When the first rib is lifted, when the second rib is lifted, it means it will increase the height of the thorax. So that means it will be creating more space for the lungs to expand. That's how we go for deep inspiration, right? So it means it will elevate first rib, right? It will elevate first rib. Else, it is connected on one side, right? On one side. So when it contracts, it can rotate, right? That's right. That's right. Very good. It is the subclavian artery between scalenus anterior and medius. Very nice. So, right, elevate first rib. It rotates. Any muscle which is on one side wide, when it will contract, it will rotate, right? Then, depending upon in association with other muscles, it if only one side contracts, so it will go for lateral flexion, right? Because it's on one side, so it will go for lateral flexion, right? And when both of them contract, so it will lead to actual flexion, that is forward flexion, right? So when we say forward flexion, that means both of them, they are contracting, bilateral contraction. When it is lateral flexion, absolutely dead, only one muscle is contracting, that is unilateral contraction. And when this contraction is phase wise, so then it leads to rotation, right? So these are the functions of scalenus anterior. Now, very rightly, you said, was this? That's right. That this is, like say, this is arch of aorta. From arch of aorta, that is brachiocephalic, right? And then that brachiocephalic would be giving that common carotid, right common carotid, and then rest is what is called as the right subclavian artery, right? On the opposite side, left common carotid will go straight, and left subclavian artery, it will travel. Whether right or left, both of them, they will be passing royally between anterior scalenus anterior and the scalenus medius, right? I'm just creating some space to write. So that is scalenus posterior. So it will be passing through that scalene gap, right? Through scalene gap. And who is passing? It is this subclavian, right? So it is this subclavian artery which is passing. And that's how the subclavian is divided into the parts, right? Part which is behind the scalenus anterior, right? Before, after, and behind, right? So that's the subclavian artery which is over there, because later on it will proceed further and it will go all the way for the upper limbs, right? So this is scalenus medius. So here it is the scalenus medius. Scalenus medius. Now see, for the scalenus medius, that was scalenus anterior, and this is now the medius. Scalenus anterior was starting from anterior tubercle, right? This medius will start from posterior tubercle. When we say anterior posterior tubercle, that means we are dealing with the transverse process, right? So no need to write that. We know that anterior and posterior tubercles. This is C3 to C6, correct? Right? The medius is one above, one below. So that means C2 to C7, right? One above, that is C2, one below, that is C7. And it was going on scalene tubercle first rib, right? Scalene tubercle first rib. So here also, there is no specific tubercle, but it will straight away be going for superior surface. But First rib, first rib, right? So same thing, this muscle will also be helping in, it elevates first rib, and as it is associated, right, it will go for that lateral flexion, right? Lateral flexion, long muscle. Moving on to the third one now, say this one, right? So that is scalenus posterior. Scalenus posterior. Now the scalenus posterior, we said that anterior, middle, and this is posterior. Anterior was on anterior tubercle, correct? So then what about this? Both of them, they are on posterior tubercle. This was C3 to C6. This was one step above, one step down, C2 to C7. They both were landing on the first rib, right? Scalene tubercle and superior surface, but basically on the first rib. This posterior tubercle, right? It is C4 to C6, but it would be landing on second rib, right? This will be landing on second rib. It means when there is a joint operation of all scalene groups, this entire gang can lift first rib and second rib collectively, and this would be very important for the deep inspiration, right? For the deep inspiration, where we need to increase the thoracic capacity so that our lungs can really expand. That's where they will come into picture, right? Otherwise, as a single one, they will always be going for lateral flexion, right? They can always go for lateral flexion. When they both contract together, they will be going for forward flexion. But important is elevates second rib, right? Which is like very important for the deep inspiration. Okay. Now this one. Still there are few topics, right? So hang on. Now we are talking about muscles which are shaping the back. Muscles which are shaping the back. One muscle. Now these are all muscles on the back side, right? On the back side. So first see this. So this is almost a vertical muscle, and this is, right? We are starting from deep. So this is semispinalis capitis. Semispinalis capitis. Right? So from where exactly it is starting? Well, it is between superior and inferior nuchal lines. It is covering that big area between superior and inferior nuchal lines. See, this is that inferior nuchal line, right? Those all small muscles, they were connected over there. This is superior, this is supreme. So it is covering that in between area. So from there to, it is going all the way down, right? So where? In fact, C4 to C7, that is all cervical, and then T1 to up to almost T6. So it is covering a long area, right? So in case of cervical, it is those superior articular surface, right? It is superior articular surface. And as it goes down, that is into the thoracic region, it goes towards the transverse process, right? Transverse process. But putting in simple words, basically it is going where? It is just going on the spine. It is going on the spine, right? Connected on the back side, right? Connected on the back side. So this means when spine is stable and such a big muscle contracts, so yes, right, it will lead to extension, right? So it extends the head, and it is powerful, right? It extends the head. Now, out of these two muscles, when only one contracts, right, that would be rotation. So it also helps in rotation of head. So that's how this semispinalis capitis. Now, how it looks like? Well, it is this muscle, right? That muscle all the way it is going. That is semispinalis capitis. Let's watch another one, right? See, beautiful muscle, big one, right? But well, instead of watching it over here, we watch this, right? Very clear, right? This is what is previously it was semispinalis, right? This is splenius capitis. From the, it is called as the splenius capitis, right? Going towards head, so it has to be splenius capitis. Now this is a broad muscle, big muscle, broad muscle. Now for its arrangement, you remember we said while we were talking about the nuchal ligament, yes, that's the muscle. It will start from nuchal ligament, right? So nuchal ligament is giving the surface area to him, plus the spinous process. That means center, right? Those spinous process. It is center all the way from C7 to T3. That means below, right? 2, it is going up to this superior nuchal line, right? This is superior nuchal line, but on the lateral 1/3, correct? This is on the lateral side. We are talking about this. So superior nuchal line, but it is lateral 1/3. Not only that, it is also going further. Now in this, it is not seen that clearly. Let's see the real image. Real. See here, right? These fibers, they are going and going all the way over here. And this is what that muscular mastoid, right? That is the muscular mastoid. Here, this is the muscle which we are talking about, right? It is splenius capitis, and this area, that is the mastoid process. So anything if it is attached to mastoid process, which is very tough, very powerful, so that's why this would be like a very strong rotator and extender of the head, right? Because such big muscle, and over here the mastoid, right? We say mastoid and mastoid. Due to this, it is when only one side contracts, it is rotator, and when both of them contract, so it is the extender. So it extends, right? When only one works, it is rotator. When both works, it is extends neck. So that is about splenius capitis. Two muscles, right over here. Nothing but all-time favorite levator scapulae. Right and left, right? This is also levator scapulae. Correct? This is lev scapulae. Now regarding levator scapulae, yes, brachial plexus also passes through anterior and scalene. That's right. So regarding the levator scapulae muscles, right? Its importance is like name itself is telling levator scapulae, right? So it elevates. It elevates and rotates. Its final action is in shoulder, right? Shoulder, right? Also, back muscle. So when it contracts, it can extends the neck, plus it is for lateral flexion, right? It is for lateral flexion. Why it is really doing this? The entire answer lies in that from where it is connected. Now in the upper limb, though we talked about it, but we never give it that much importance. Now see how interesting it is. It is connected to all the way from C1 to C2 to C3 to C4. 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 Right? Now on C1 and C2, it is just the transverse process because there is nothing like tubercle. So whatever transverse process is available, connect. C3, C4 is also transverse process, but posterior tubercle. This means this muscle is more or less posterior connected, right? And then it goes towards the scapula. Now say in scapula, right? In scapula was, if we draw it very crudely, right? It was something like this. This was the spine, right? So this was that superior angle, right? This was superior angle. This was inferior angle. And that's where the joint was formed. That is that lateral angle, right? This one would be the spine. This one would be the spine. Levator scapulae would be attached on this superior angle. And this one would be the medial border, right? This one would be the medial border, right? So medial border above the spine. So that's the area of levator scapulae. Now think of, it is connecting with C1, C2, C3, C4, right? Where means transverse process, posterior tubercle, wherever, but laterally connected, and then coming down and just pulling this bone only from that 2 points. So how strongly it can really pull, right? This is the beauty of it, that it is like when the scapula is fixed, well, the neck would be rotated, right? When both of them are contracting, neck would be extended. But when the ulta thing happens, when the neck head is stabilized, so at that point it would elevate the shoulder, right? Because head is stable, it would elevate the shoulder. This is the reason in gym, right, when you are taking the dumbbells and then say that okay, raise your shoulders, but then say keep your head straight, right? Don't bend it, watch straight. Watch straight. So that means your all the cervical C1, C2, 3, 4, they are stable, right? And then you are lifting. So this is because these are the muscles which are actually giving good cuts or to your back. So that's the reason this muscle is, those exercises, they are defined like that. That's the reason that every time it is said that whenever you perform any of the exercise, form is very important. It is because of this reason, right? So over here, it extends the neck and lateral flexion when rest of the body is fixed. But when the head is fixed, it will elevate. It will elevate, right? And it would rotate the shoulder. Now, when it is asked that, okay, it would rotate the shoulder, at which joint, right? This is also very interesting to know. At which joint will it happen? Well, think it this way. Scapula can move only on certain axis, because say on scapula, right, this is the spine, right? There is acromion process and then there is clavicle, correct? So that is at acromioclavicular joint. So one, it will happen at acromioclavicular joint, correct? And then that clavicle would go all the way to sternum, right? So there was plus sternoclavicular joint. sternoclavicular joint, because this movement is with respect to trunk with the entire body. So when the body is fixed, so then these are the only two available, because this is the clavicle, right? Sternoclavicular and acromioclavicular. So this is how it really works, right? So that's the levator scapulae. And the levator scapulae over here, these are the levator scapulae, right? This one and this one. This next one, this is, that one was called as splenius capitis. So over here, this is called as splenius coli, right? Or splenius cervicis in the same thing. So looks itself is telling that starting from spinous process all the way from T3 to T6, that is, it goes at the thoracic level, and on top it goes to those transverse process into the cervical region from C1 to C3. So two extremes, right? Two extremes. So same functions, extends when both are working together, rotates, and the lateral flexion. So for the lateral flexion, only when one muscle is contracting, this is when both of them are contracting. So this takes us to the final muscles, right? And this one is traps or the trapezius, right? Trapezius has been discussed at length when we were talking about in upper limb, but still these are the three sets of fibers, and we have to remember it like this. This is the direction. So that's why these topmost fibers, they are called as the descending fibers, these are called as the transverse fibers, and these are called as the ascending fibers, right? From the perspective of head and neck, only the descending or these top fibers, right? These fibers, they are of importance, these fibers. So for these top fibers, from where will they start? See, the top. So they will be, so we are talking about upper fibers, right? Upper or descending fibers. So they will start with external occipital protuberance over here, right? So external occipital protuberance. So it will start from there. Then see the superior nuchal line, right? That superior nuchal line. Superior nuchal line. Then it has to be nuchal ligament because such a big muscle, so it will require more surface. So nuchal ligament. And C7 spinous process. C7 spinous process. So that's how it starts. And then it would go all the way to, it will go posteriorly to lateral 1/3 of the clavicle, right? Say we were discussing it, right? Lateral 1/3 of clavicle and the acromion process, right? Acromion process of scapula. So it goes laterally. So when the top muscles would contract, so it will go for extension or the lateral rotation. And similarly, it can also work for the shoulder, right? So this muscle, it works exactly like that levator scapulae, only the upper fibers if we are talking about. So it can give lateral rotation of neck, extension if both the sides they work together, and it works on shoulder also, right? It can work on shoulder also. So that's why those shrug, right? Elevation of shoulders. And whenever we say shoulder movements, so then they occur at acromioclavicular and sternoclavicular joint, right? Don't forget this, right? Simple as that. Now see, as we are talking about, so this transverse process, I mean transverse fibers, not transverse process, transverse fibers, right? These transverse fibers, here it was C7, right? This one, the descending fibers. Over here it starts with C7, right? And goes all the way up to T4. So that's where the spinous process, so that's from where it starts. And it will go towards same, right? Acromion process. But here, say, it was lateral 1/3 clavicle, right? Here it is medial 1/2 of the clavicle. And same way, when we talk about this ascending fibers, so they will be from level T5, where that ends, right? And all the way up to T12. So that's the reason it fans out at such a big level, right? And then it goes to the spine, right? I wrote clavicle. Oh, sorry. This has to be spine of scapula, right? Not clavicle. Because see, right, that's how. And this is the spine, and that's the area which is covered by, right, the trapezius. So that's how this spine, in this case, that was medial half, right? Here also it would be covering that fibers, and that's how they work. This will be working more or less on shoulder, right? So that's why for head and neck, only the upper fibers, they are involved. Yeah. So here, that is the trapezius, right? As we look from the back, that's the trapezius, traps. And yes, these are all descending fibers. This is when you watch from the front, right? So these are the traps. The final muscle of today is the most interesting muscle. This is sternocleidomastoid. Sterno is sternum, cleido is clavicle, mastoid is muscular mastoid, right? So here it is mastoid, and then sterno and clavicle, they are over here. This is sternocleidomastoid muscle, right, which starts from behind the say ear. That's the mastoid process, and then all the way it goes downwards, forwards, and medially, right? It goes over here. That is the sternocleidomastoid muscle. And see, this is how it lands, right? Where this is the clavicular end, and this one is sternal, right? So that is top one, sternocleidomastoid, sternum, clavicle, and the mastoid process. Let's see it over here. Now it makes sense, right? Very clear. This sternocleidomastoid, it will be starting from two things we have to add. Say one, we said that mastoid process, that's from where it is starting, but also add. And this one would be very crucial. So I'm changing the color. Superior nuchal line. Else, I'll be telling its function, that what it does, and you'll be wondering that how is it possible. Rest is all okay. From here, right, it will go all the way to manubrium sterni, right? Manubrium sterni, because that would be the manubrial head. And for the cleido, that is the clavicular head, it would be the medial 1/3 of clavicle. Well, so far so good. What about its function? The first function, right? Because other functions, so they are fine. When both the sternocleidomastoid, they will contract, right? It would be flexion. So bilateral contraction, that is flexion of head. Now comes the interesting part. When there is contraction of one sternocleidomastoid, right? Contraction of one sternocleidomastoid, it will rotate the neck on the opposite side. Rotates neck on opposite side. Really? Opposite side. To see this thing, that actually opposite side, rotate the neck on the opposite side and try to touch the muscle over here. You will find it is soft. While on the opposite side, it is very strong, tight. Now, how is it? How is it really doing it? Right? Try to do it by yourself. Right? Rotate your neck on one side and then touch it. It is absolutely soft. Right? Absolutely soft. But when you test opposite side, yes, it is very tight. It is because it is from over here. Here, so it is fixed. But then it is going over here and it is going on superior nuchal line. Right? So when that thing contracts, when this muscle contracts, in fact, the movement would be relatively on the opposite side. Right? It is because the muscle is giving the pull on the opposite direction. So when you are like when this muscle is contracting, it is the back side of the superior nuchal which is pulled over here. Right? Now this is contracting. So opposite, the rotation is on the opposite side. So when my left muscle is contracting, head is moving on the opposite side. When this contracts, right? This contracts, so it is pulling my superior nuchal near my shoulder. So that's why I'm watching on the opposite side. So this is the point to understood. And when we'll be talking about its clinical implementation, not today because it will become very heavy, but something which is called as the torticollis, right? Torticollis. So this concept would help you a lot. So remember, contraction of one sternocleidomastoid, it rotates neck on opposite side, right? So this space, right? This space, that hollow space from where the trachea comes, right? So that is defined by this hollow space, that is defined by two sternocleidomastoid. This is sternocleidomastoid. So that's why it is so important. Another thing is these muscles that sometimes when the head goes back, right? When the in boxing, right? When the punch is on the head, on the face, right? So head tries to go back, and then you need to take it back. Otherwise, it will lead to coup and counter coup mechanism. Brain can be damaged. So that's the reason. If you have seen those boxers, they really do the neck exercise so that their necks are so powerful. It is this sternocleidomastoid which will keep the neck from falling behind, right? So these SCMs, they prevent neck from falling behind. All right. So now this skull is happy, right? That you talked so much about me. Thank you so much. And yes, it was like a marathon session. So thank you, and the file has been saved. I'll be putting it into our folder very soon. Thank you and bye-bye. See you tomorrow. Good night.